Hi guys, our next lecture on electric stimulation is Estim Techniques. And in this lecture we're going to talk about primarily the types of Estim that we use and the reasons why we use Estim. So our goals of treatment with using Estim. So there are a couple major therapeutic uses that we use for Estim. One is pain control. So controlling acute and chronic pain. Reducing muscle spasm would fall under that category as well, because typically if people have muscle spasms, they're going to have pain associated with that as well. Another major treatment area is edema control, so reducing edema in order to allow healing to occur. And then the third major area is going to be muscle reeducation, or minimizing disuse, atrophy, trying to get a muscle to contract again. So those are our three major treatment areas. So pain control, edema control, and muscle reeducation. And we'll talk about the different types of stim that are best for each one of those treatment goals. So the effects of Estim are going to depend on the type of current that we choose, the parameters of that current, which again, once you choose the waveform or the type of current, the machine is going to choose a lot of those things for you. The size of electrodes that we use, and also how we arrange the electrodes on our patients. The effects of Estim happen because we depolarize nerves, and we're going to depolarize nerves in a very predictable order. We can depolarize sensory nerves, motor nerves, or pain nerves. And then there can also be some electrochemical changes that happen beneath the surface as well. So I mentioned this in the last lecture, but tissue is going to conduct electricity at different rates, and the tissue's ability to conduct electricity is going to be based on its water content. So basically, the higher the water content of the tissue, the more easily it's going to be able to conduct electricity, so increased conductivity. Tissues are considered to be either excitable or non-excitable, and some of the excitable tissues are going to be nerves, muscle, cell membranes, and that's good because that's typically what we are trying to stim with electricity. Non-excitable are going to be things like bones, cartilage, tendons, adipose, ligaments. So that's one thing to keep in mind, especially like tendons. When we're trying to stim a muscle, we're going to talk about electrode placement and how important it is to always place the electrodes on the muscle belly because tendons aren't quite as excitable. So as I mentioned in the first lecture, skin is going to be our primary resistor to Estim. That outer layer of skin, it's really, really dry, right? That's why it flakes off and we lose it every so often. But it has a very low water content, so it's a poor conductor. So that's why it's initially difficult for Estim to get into the tissue. Remember, bone, tendons, adipose are also poor conductors. So this is, again, another instance where adipose is going to be more of an insulator of the underlying tissues. If a patient has a lot of adipose tissue, we do need to be concerned that we are going to be able to reach down to the target tissue for our treatment. Cell membranes, because they are a phospholipid bilayer, they are also somewhat resistant to current flow, but we are typically able to overcome that. Muscle, nerve, blood, again, all have high water content, so those are all considered to be pretty good conductors, which again is good because that's typically what we're aiming for with our treatments. So the current is going to enter the body through a series circuit. Series circuit, again, is, remember, one set route, so that's where the electrode is placed on the tissue, and then once it enters the tissue, it will form parallel circuits and find the path of least resistance. So it's almost as if it's going to seek out the blood, the muscle, the nerves, the things we want it to target. There will be some physiochemical and physiologic reactions when you pass electricity through the tissue. And if you're using a low and moderate frequency, that means very low pulses per second. That can mean that you almost feel sort of like a pulsating with the current. There can be some potential thermal changes with that as well. When we use high frequency, which again, remember, high frequency is going to meet less tissue resistance, there are typically no thermal changes associated with that. And some of the types of Estim that we use, like interferential current, those are typically preset to be at a high frequency. We're not going to have any thermal changes happening with them. When we do have thermal changes happening in the tissue, it is typically because we're causing muscle contractions. The muscles are contracting and that's producing some heat. So the electrode leads, those are the wires that go from the generator to the electrodes that are going to be attached to the patient. We need a minimum of 2 leads to complete the path. So regardless of the type of E-stim we use, regardless of the setup, know that 2 leads. We need 2 electrodes at a minimum attached to a person in order to get the electricity to flow. There are special safety measures that are built into all of the machines that are protective, right, for the patient and for you, to make sure that we're not getting any unintended contact with electricity. Most will have a special plug. The plugs with the 3 prongs, that helps to ground that. So again, we're not getting any unintentional electricity delivered from the wall. The units themselves are going to shape the electricity into certain waveforms that are more tolerable by the body. So we have a couple safeguards in place. Plus, our machines are inspected on an annual basis, and that is probably the biggest thing they're actually looking for, is that are the machines safe, that they're carrying electricity the way that they should, and they're not going to cause harm to anyone. So there's lots of different types of electrodes out there. They can be made of different polymers, metal, carbon impregnated silicone rubber, all sorts of different materials. But again, to form a closed circuit with the body, you need 2 electrodes in firm contact with the skin in order to actually close that circuit. We need, again, that even distribution so that we don't have any hot spots develop. And if your electrodes aren't sticking very well to your patient, that is potential for uneven distribution of electricity and a potential for burns. So once your electrodes start to not stick anymore, it's probably time to get another set. So let me know. I always have a few extras on hand. So if your electrodes start to lose some of their stick, we'll swap them out. The electrons are going to be converted again, by the machine to allow them to flow within the body. And again, there's lots of different types. Water, gel, self-adhesive are the kind that we're going to use most often. They're easily available. They're not terribly expensive. And the nice part of them is because they have self-adhesives, they will conform to any contours of the skin. So you can perform E-stim over an irregularly shaped body part because the electrode's just going to stick right to it. The type of electrode is going to affect the efficiency and the comfort. Carbon rubber deliver a lot of current with the least resistance. Those are typically considered the most comfortable. Self-adhesive do have some resistance to flow. There is some potential for burns. It is usually because of the adhesives, and what happens is you pull them off the patient when you're done with treatment, and off comes some dead skin cells and hair cells and some oils and things like that. And then every time they're reused, that happens over time, that starts to build up, and then we can actually develop some hot spots. So again, when you realize that your electrodes aren't sticking so well, swap them out for a new pair. There are metal electrodes that used moistened sponges. This is not as scary as it sounds. I did actually see some machines like this when I first started working. You use tap water, but that's not always the best because there's some minerals and impurities in that. But there is no increased incidence for burns. That's what everybody thinks of. Like, you're going to burn the person because you're using water and electricity and metal and all this stuff. But they were somewhat large metal cutouts. You did take sponges and wet them and put them inside the metal cutouts, and then you place them on the patient. So they weren't self-adhesive, so you had to either use gravity to kind of hold them in place or use Velcro straps to hold them in place. So once self-adhesive electrodes became more and more popular, we've pretty much just switched completely to those. Do keep in mind, some of your patients may actually have a reaction to the adhesive in the self-adhesive electrodes. So one of the things when we take off the electrodes, we always look for any skin irritation or anything like that. Sometimes it can be from the E-stim, depending on the type of stim that we use, but sometimes it could be from the actual electrodes themselves. So sometimes we need to swap out like the brand or try something else with those patients. As I mentioned in the last lecture, the electrode size is going to inversely affect current density. So the smaller electrodes, the more dense the current is going to be, the greater the perception for the patient. So again, example, pass the same current through a 10-inch and a 5-inch electrode. The 5-inch electrode is going to have 2 times the current. The patient's going to feel more electricity in the smaller electrode. How well it contacts the skin can influence the parameters, again, patient comfort and muscular tension if that's your goal of treatment. Most electrodes are going to have a maximum current density that can't be exceeded. It should be written on the packaging, but with all the types of e-stim that we use, it's going to be very difficult to exceed that. The size of the electrode that you choose can be determined by the body part that you're treating. So if you're treating a larger area of the body, you can choose a larger electrode to cover that. If you're treating something small, you're going to want to choose a smaller electrode. Sometimes this is determined by your clinic. Sometimes they only have one size of electrode, so that's what you're going to use. Some places I've worked have sort of like a smaller electrode and a larger electrode. So again, I would go based on what size body part am I treating, choose a smaller electrode for something smaller, larger electrodes for larger body parts. If you're trying to get a muscle contraction, it's going to be an isometric muscle contraction. If we use larger electrodes, we're going to be able to recruit more muscle fibers. So you should get a better contraction if you use larger electrodes. So as far as your electrode placement goes, some areas of skin are going to be more conductive than others. These are called stimulation points. So this is why sometimes if you have your electrodes on a patient, or if you're trying e-stim and you have 2 or 4 electrodes placed on, but you feel it more under one than all the rest, it's the same current running through all of them, but one might be placed over a stimulation point. So if this is something that bothers you or bothers the patient, what I would do is just turn the machine off, reposition the electrodes, and try it again. The proximity of your electrode placement is also going to determine the depth of penetration or stimulation in the tissues. If the electrodes are placed relatively close together, the treatment is going to stay more superficial. If the electrodes are placed further apart, the current is going to be able to run deeper. With that being said, do be careful how close you place your electrodes to each other. Think back to like handwriting and learning that we need at least 1 to 2 finger spaces between our electrodes. If you place your electrodes too close to one another, the electricity is going to flow between them, and you can actually get some arcing if they're too close, and you can actually burn your patient that way. So make sure that there is a little bit of space between your electrodes. As far as I know, there is no limit to how far you can place them. I have seen people where they've done treatments where they've maybe, say, placed an electrode up on the neck and the other one down on the hand to follow a nerve path. That's fine. So you can spread them out pretty far. Depending on the way that the machine is set up, more than one electrode can be connected to a single lead. We have one machine that's kind of a little bit different, so I'll show you that in lab. But for the most part, most leads will branch into 2. You'll have 2 electrodes off of one lead. All right, so there's 3 major treatment setups for your electrodes. We can have the monopolar technique, which we'll talk about first. There's a bipolar technique and a quadripolar technique. So for the monopolar technique, we're going to have an active electrode and then a dispersive electrode. So we're using current density to our benefit here. So what we do, monopolar technique, again, mono means 1, right? But remember a few slides ago where I said you always have to have 2 electrodes in contact. That is still true here. So even though it says it's a monopolar technique, we're having 1 active electrode and 1 dispersive electrode, but there are still 2 electrodes going to be attached to our patient. So the focus of treatment is under the smaller electrode, right? Because of current density. Same current running through 2 different sized electrodes, one smaller, so the current is going to be more concentrated there. The patient's going to feel it more under that one. And then we have a larger dispersive or grounding electrode attached to our patient somewhere else, which is going to spread the current out over a larger area. The patient's not going to feel that one quite so much. So again, the surface area of the dispersive electrode should be much larger, again, so it spreads out the current a little bit more, and that is also referred to as our grounding electrode. 1 active, 1 dispersive or grounding. So it is monopolar because we have 1 active electrode, but we still have 2 attached to our patient. Then we get into the bipolar technique. So actually, go back 1 second, sorry. Monopolar technique, that is going to be iontophoresis. So again, we're going to get to that a little bit later. A lot of what we're going to do in the lab right now is going to be using 2 electrodes of the same size, which is where we get into the bipolar treatment technique. So both of these electrodes are going to be placed within the target treatment area. Again, stimulation may be felt more under one if it's placed over a motor point or a stimulation point, but it should be pretty equal because we're using equal sized electrodes. The person should feel the stimulus pretty equally under both of them. Again, if they don't, stop it, try to rearrange them and see if that helps at all. But with the bipolar technique, again, it's 2 electrodes, they are the same size, and they're both going to be placed in the target treatment area. We're going to use this for muscle re-education, a little bit of pain control, maybe some edema control as well. And then the quadripolar technique. So this is 2 sets of electrodes, each runs from its own channel. This is how we set up interferential current. So by definition, interferential current is going to use 4 electrodes that run off 2 different channels, and then the current sort of interferes or intersects in the middle, so that's where we're going to have the most pain relief. So in this picture here, you can see this patient is obviously having some neck pain, and so they're setting up treatment around there. If you look really closely at this bottom picture, you'll see there's a red lead, and those channels are running this way, and then there's 2 black leads, and that channel is running this way. So one of these is channel 1, the other is channel 2, and they're crisscrossing. So again, we're going to have interference here in the middle, and this is where the patient's going to experience the most pain relief. So this is almost a foolproof treatment setup. All you need to do is ask the patient where they're hurting, and then take your electrodes and surround that area. Just make sure your channel 1 and channel 2 are crisscrossing, and then you should feel stimulation pretty much in that whole area. So selective stimulation of nerves. I did mention earlier there is a very predictable order in which Estim is going to stimulate nerve tissue. It's based on the diameter of the nerve, the depth in relation to Estim. So larger nerves are going to be stimulated before smaller nerves. That's the diameter of the nerve. Depth in relation, more superficial nerves are going to be stimulated before deeper nerves. And then the duration of your pulse or your phase, which is going to be determined by your waveform in your machine. In general, always, always, always. Again, here's one thing I can give you that's pretty black and white. Sensory nerves are always going to be stimulated first. Sensory information is typically carried on larger diameter nerve fibers. So sensory nerves are going to be stimulated first, then motor nerves, then eventually pain or nociceptors will be stimulated after that. This is going to be based on the intensity or the amplitude of your wave. So basically, no matter what type of stim you set up your patient on, as you start to turn the intensity of the machine up, first they're going to start to feel it. That's the sensory nerves being stimulated. If you continue to turn up the intensity, eventually you will get some muscle twitching. That's motor nerves being stimulated. And if you continue to turn up the machine after that, pain nerves will eventually be stimulated as well. Pain is typically carried on the smallest diameter fibers, so those are going to be the last ones to be stimulated. So again, these are our stimulation levels. First, there's a subsensory level. So that means you have your electrodes attached to your patient, the machine's on and running, and you start to turn up the intensity. For a few seconds, they're probably not going to feel anything just yet. This is the subsensory level. So this is from when you start to turn up the machine to when they report they actually feel some of that stimulus. At that point, it's sensory stimulation. The sensory nerves are being stimulated. They can feel a tingly sensation is typically how patients are going to describe it. And then again, if you continue to turn up the intensity, you will get a muscle twitch. Typically, if we're trying to do muscle re-education, this is what we're aiming for, right? We not only want the muscles to twitch, we want them to contract. So once we get the muscles twitching, we need to continue to turn up the intensity a little bit more until we actually get a nice tonic contraction. Once we get to that point, we start the machine, it fires, it stimulates the motor nerves, and then it usually rests for a period of time. So we'll get to duty cycles or on-off cycles when we get into the actual treatment for that. Again, if you would continue to turn the intensity of the machine up past the point that we're getting a tonic stimulus, you will eventually start to stimulate noxious or nociceptors or pain fibers as well. There is one treatment technique where this can be utilized, and I'll talk about that a little bit later. So one thing that can happen when we're stimulating a patient is they can accommodate to the stim. If you've worked in a clinic or if you've ever had Estim before, what can happen is once you get sort of used to the Estim, it feels like the intensity is decreasing. It's sort of the same thing as habituation if you skip down a little bit, where your central nervous system is going to filter out continuous, non-meaningful stimuli. Like if you sit down to study and the refrigerator's humming in the background, eventually you don't really hear it or pay attention to it anymore because your CNS filters it out. So the same thing can happen with eStim, especially when you have like a constant continuous current. So things like interferential stim, a lot of the types of stim that we use for pain control, we keep on a continuous setting. So your patients can start to accommodate to that. So there's something built into the machine called modulation parameters, and each of the machines calls it a little bit something different. But what it is it's a setting that's built into the machine where it'll actually alter your wave a little bit or alter the flow of the electrons a little bit so that the person doesn't get as used to it as quickly. And so when we get into each of the machines, I will show you how you can set that up. Some machines default to it, some do not. So you can play with that a little bit. You can actually play with it while the machine's running so you can feel the difference between having the modulation parameters on and not having them on. All right, medical galvanism is a specific type of eStim. It's low voltage direct current. So direct current, remember, is that continuous type of current that stays either positive or negative. Again, we can have cathodes and anodes. Cathode is going to be a high concentration of electrons. This is more of a negative polarity. So if you apply a negative treatment to your patient, that will cause the local pH to become more basic. There's a slight increased risk for burns for that. It can help to soften the tissue if your patient has a lot of necrosis, and it can decrease nerve irritability. If you set up your patient for a positive treatment, you apply the anode to a particular area. The pH in the area is going to become more acidic, and it can cause coagulation. So if your person has issues with clotting or they're bleeding, this could potentially help with that. So we typically use these when we're dealing with wounds, really not many other types of treatment, but again, depending on what your goals of treatment are, you can use medical galvanism or this direct current and the properties of either a negative or a positive treatment to help with your treatment goals. We can also use medical galvanism to contract a denervated tissue. So I'm not sure if we've mentioned it yet or not, but when we get to like muscle stimulation, if you want a muscle to contract, we're working under the assumption that that muscle still has intact nerve fibers. It's just kind of forgotten how to contract because of injury or surgery or things like that. And so we just need to retrain it. If a muscle becomes completely denervated because of an injury to the central nervous system, like a stroke or a spinal cord injury, after a period of time, we're not going to be able to stimulate that muscle by traditional eStim techniques. So sometimes medical galvanism can be used to elicit a muscle contraction there. All right, so moving into our goals of eStim. So motor level stimulation, if we're trying to get a muscle to contract, there are specific types of stim that are going to allow for a more efficient, intense, and comfortable contraction. It is going to depend on the rise of the pulse duration, and the amplitude of the current, which is again why we choose certain types of eStim based on that goal. Generators that are designed for neuromuscular stimulation will help to produce a strong tonic contraction, and they are pretty comfortable. So most of the neuromuscular eStim units that we have are typically handheld battery units, at least the ones that I've seen in the clinic. None of our machines that we use have a neuromuscular eStim button. What we typically use in place of that is Russian stimulation. So let's talk about physiologic muscle contractions versus electrically induced muscle contractions, or ones that we're going to force with eStim. So with a physiologic contraction, your small diameter, slow twitch fibers are going to be recruited first. With an electrically induced contraction, we just talked about large diameter fibers are always stimulated first. So your fast twitch fibers are going to be recruited first. With a voluntary or physiologic contraction, they're going to be asynchronous in order to decrease fatigue, right? Your body's not going to fire all muscle fibers at one time. With eStim, we can't selectively choose to fire some muscle spindles and not others. It's going to be based on our pulses per second. We're going to stimulate those large diameter fibers, and we're going to get a strong contraction. With the physiologic contraction, the Golgi tendon organs can protect the muscle from too much force production. With electrically induced, the Golgi tendon organs can't override the muscular tension that's built up, but you'll see that usually we're going to get to that noxious level of stimulation well before a person would have any type of damage or too much tension developing in the muscles. All right, so pulse amplitude. This is basically the intensity of the E-stim. So the strength of a muscle contraction is going to increase as your intensity increases. So like I said, the first thing you're going to notice is some sort of twitching of the muscle, and then eventually you'll get a nice strong tonic contraction. This is most often going to be limited by your patient's tolerance, right? It's not because the machine won't do it or their muscle fibers aren't responding. Patients just aren't super comfortable doing this. If you've never experienced an electrically induced muscle contraction, you're going to when we're in lab. It does not hurt. I promise you that. I'm not signing you all up for anything that's going to cause you any pain or discomfort. It is weird. It is weird because your muscles are contracting and you're not making them do that. So it's an unusual type sensation. The reason patients may have some pain with it is that we're getting a muscle to contract that was just involved in a surgery. I'll say one of the major things we do is like quad stim with our patients following ACL reconstruction. So it's not so much that we're hurting their quads or causing pain by applying E-stim, but we're forcing their quads to contract. That's putting tension on their knee, and their knee was just operated on. So that's where patient tolerance comes into play. So really giving your patient a good explanation of what it's going to feel like, maybe trying it on a different body part or trying it on the opposite leg first if they're really fearful of it. May even try it with cold, then they won't feel the sensation quite so much. There's some mixed results with that. That doesn't work for everyone, but those are a couple ideas you can try. But again, if the goal is to get a muscle contraction, we have to actually see a muscle contraction. So we have to get to that intensity of stimulation to actually see a good muscle contraction. Phase duration is going to help determine the quality and quantity of muscle contraction. 300 to 500 microseconds is going to recruit motor nerves. Shorter phase durations are not as likely to evoke muscle contractions, and again, pain is typically going to prevent a maximum contraction from being achieved. We typically don't have to choose phase durations. We choose a type of stim to get a muscle contraction, like Russian, or high volt works pretty well for muscle contractions as well. And then once we choose those, we're choosing those waveforms because we know that they have those longer phase durations and will be better at producing muscle contractions. So looking at pulse frequency, if we use a low pulse frequency, we're most likely to get a muscle twitch. Medium, we can actually get more of a summation of those muscle fibers, and we typically need to use a higher pulse frequency, at least 40 pulses per second, if not higher, in order to get a good tonic contraction. Again, by choosing the appropriate type of E-stim, Russian or high volt, those are going to default to our higher frequencies or higher pulse frequencies, which is going to allow us to get a better contraction. Denervated muscle, we talked about that earlier with the medical galvanism. Again, if it's been less than 3 weeks, we can still probably depolarize the muscle or the nerve fibers with traditional E-stim techniques. Again, if it's been longer, we'll probably have to use medical galvanism, which is direct current, or a monophasic current with a fairly long phase duration. So we'll have to alter our currents a little bit in order to get a contraction with denervated muscle. So neuromuscular reeducation, this follows along with muscle contraction. This is sort of teaching a muscle to contract again after injury or surgery. It reestablishes that neural pathway so that the person is able to voluntarily contract their muscle again. The typical duty cycle for neuromuscular reeducation is 10 seconds on and 50 seconds off, which doesn't sound like a lot. Treatment time is usually about 10 minutes. So in that time, they're going to do 10 contractions for 10 seconds. With this muscle that is very deconditioned, you can actually induce muscle soreness with that. So again, while it doesn't sound like a lot, this is a muscle that hasn't been used for a while. It is atrophied. The person is having difficulty voluntarily contracting that muscle. So 10 seconds on, 50 seconds off is usually plenty. What we'll do is we'll also tell the patient to contract with the machine. So when they start to feel the machine turn on, they can try to contract their muscle with it. The more work the patient does, the less the machine has to. So if this is a patient who doesn't tolerate this type of E-stim very well, the more they can try to contract the muscle, the less intensity we'll have to use on the machine, and typically the more comfortable it is for them. We can also adjust the ramp to make it more comfortable for them as well. So if we have that person who is a little timid, who is not as tolerant of E-stim, go ahead and increase the ramp a little bit so you have a more gradual increase to that maximum intensity, and that may make them tolerate treatment a little bit better. We don't want to go too slow though, because if we go too slow, the person will start to accommodate to the E-stim, and then we might not get a good, strong contraction. So try to find that happy middle ground. Again, the frequency has to be enough to cause a tetanic contraction. Most of the machines are going to default. Remember, we said we need at least 40 pulses per second. Most of our settings are going to default to at least 50 to 60 pulses per second. And again, that's why we choose specific types of E-stim like Russian, neuromuscular E-stim, high volt, if we're trying to do neuromuscular re-education or get a muscle to contract. So as far as strength augmentation goes, electrically induced muscle contractions can actually supplement strength gains, but they're not going to substitute for voluntary contractions, right? We're just retraining a muscle because the person can't do it voluntarily. This is going to be an isometric contraction. This is not necessarily going to carry over into isotonic or to isokinetic strengthening, but you have to be able to do an isometric contraction before you can start doing isotonic strengthening, right? If you can't even isometrically contract your quad, there's no point in me putting weights on your ankles and trying to get you to do quad exercises that way. You're not going to have the strength to do it. So using E-stim is going to help the person learn how to do isometric contractions, which then once they're able to do those pretty well, then we can progress into isotonic strengthening. Again, the stimulation has to overload the muscle. It's often too painful. This is why those machines that they sell on TV that you put on your abs to make them contract like all day long, they're not really going to give you a six-pack. That's not how this works. And so it'll help with isometric strengthening, but no one gets big and strong and nice big muscles from doing isometric exercises all the time. They actually have to lift weights and do isotonic strengthening for that to happen. So this is typically just a precursor to doing more strengthening. Okay, so now switching gears a little bit to pain control. We can assist with the healing process by using E-stim, or more likely what we're doing is going to affect the transmission or perception of pain. So we typically use high pulse frequency, short phase durations at the sensory level to activate the gate mechanism. So I believe we've talked about the gate mechanism of pain control, but if not, let's talk about it right now for a second. So hopefully just a review. If not, okay, good, new material. So let's say you go to sit down at the table and you bang your knee on the table leg underneath. What we might do is start to rub our knee in order to make it feel better, right? You've all done something like this before. What's happening is that when you banged your knee on the table leg, that was a noxious stimuli. You stimulated nociceptors on those small diameter fibers, and it's carrying that pain signal up to your brain. When you rub your knee, what you're doing is you're stimulating those larger diameter fibers, and now your brain is getting this rubbing sensation instead of the pain sensation. So we're using a non-painful stimuli to override the painful stimuli. It's the same thing we do with E-stim. Someone comes in, they're in pain. Pain is being carried to the brain on small diameter nociceptive fibers. We introduce E-stim. The E-stim is going to stimulate those sensory fibers first. They're going to get that tingly sensation, and that tingly sensation is going to override the painful sensation. So they have a period while they're on the machine, and it should usually last a little while after as well, where they will get some pain relief. We can also set up treatment a little bit differently, where we use a low pulse frequency, moderate pulse duration, high intensity stimulus to get a release of endorphins. And there may also be some placebo effect used in all this as well. We can use E-stim for wound healing. We're not going to do a whole bunch of this in lab, but do know that E-stim has been proven to help with healing wounds. We typically use a low intensity direct current or a high volt current. And the reason we use that, or use those two types of current, is high volt is a monophasic current. So what both of these have in common is that they are either a positive treatment, or we can at least set them up so that they would be a positive treatment or a negative treatment. So earlier in this lecture, we talked about some of the benefits of having a positive treatment versus a negative treatment. So again, if there's wounds, we might want some of those physiologic things to happen. So they found in some studies that applying these types of currents actually helped wounds heal up faster than people who are not getting any E-stim. The electrical current can kill microorganisms, produce antimicrobial effects, attract healing factors to the wound. The negative polarity can break down and absorb blood clots, so if there's clotting in the area, negative can help with that. And tissue repair can be sped up because we're increasing circulation, some of those antibacterial effects, bringing new cells to the area, and the presence of an injury potential. So E-stim can help with wound healing, and if you do use E-stim for wound healing, it is most likely that you'll be using either direct current or high volt current for that. And then the third, or one of the other major treatment areas is going to be edema control. So there's two major ways that we can use E-stim for edema control: sensory level and motor level. Sensory level, the idea behind this is that we're going to limit the initial formation of edema by causing a vascular spasm in the area and preventing fluid and proteins and other solids from leaking out into the area. So with that, we have to catch the person typically within the first 6 hours after their injury before the swelling develops. Now again, clinically, we're not going to see that a lot. We don't see people that acute most of the time. We see them later on down the road. So clinically, most often what we're going to use is motor level edema control. And that has been very highly researched. It is very well established. We can absolutely use E-stim at the motor level to reduce edema. So this was for previously formed edema. So this is after that 6-hour window. And this is just going to help with venous and lymphatic return of the fluid that has built up. So basically what we're going to do is we're going to induce muscle contractions to force that muscle to pump, basically creating a milking effect to get that edema out of the area. So if you're doing sensory level stim, you're going to choose high volt for that. There are no other choices. Sensory level edema control, you've caught that person within the first 6 hours following injury. There is not a lot of edema yet. We're going to try to stop the edema from happening. So we're going to apply high volt pulsed current directly over the area of injury, and we're going to run it at a sensory level. It's going to feel like pain control because we're just going to feel the tingly. We're not looking for muscle contractions or anything like that. But the idea is that we're reducing capillary pressure and permeability, which will help to cause a vascular spasm and prevent the fluids from leaking out. So again, the whole idea here is that we're going to stop the edema from forming in the first place. Again, more typically what you're going to see is motor level edema control. This has demonstrated clinical efficiency, efficacy. It works. We know this. So we're going to induce muscular contractions and milk the fluids out of the area. The electrodes do need to be arranged on a nearby muscle group. So if we're doing sensory level edema control, we place the electrodes right on the site of injury. If we're doing motor level edema control, we're going to put it on a nearby muscle group. So let's use the example of an ankle sprain. If I catch that person before the ankle has swollen up, I'm going to put my electrodes right on the lateral side of the ankle where they sprained it most likely. I'm going to run high volt. I'm going to run it at sensory level to try to prevent edema from forming. Now, if that person sprained their ankle a couple of days ago and they end up in the clinic, now I'm going to do motor level edema control to try to get rid of the swelling. And I'm going to put those electrodes most likely on their calf muscles and try to get the calf to contract to pump some of that fluid out of the area. I'm going to pair that probably with some ice, with some elevation, try to get all those things working together to try to get the swelling to go down. If we can, we want to arrange the electrodes so that the muscles contract distal to proximal. We're going to use a 50% duty cycle. The contractions do have to be within the patient's tolerance, and as I mentioned, elevate as well. If you want, you can apply some ice too to really help with edema control. All right, so not so much us, but doctors are looking into using E-stim for fracture healing, and they actually are using some E-stim for fracture healing. They would actually go in and surgically implant tiny little electrodes to stimulate bone growth or bone regeneration. They're known as bone growth stimulators. I have seen a couple of patients that have had bone growth stimulators. The idea is that these little implanted E-stim units are going to produce an electromagnetic field that's going to mimic normal electrical signals, which will hopefully help to lay down more calcium and help the bone to regrow. The usefulness is being debated. They're not very useful for stress fractures. They're generally used for non-union fractures. So the two places I've seen them, I did treat a patient following a car accident who had a fracture of her femur, and it was a non-union fracture. It had been weeks and weeks, and the ends of the femur were just not growing together the way that they should. So what the doctor did was actually implanted a bone growth stimulator to try to get the femur to heal fully. Another person I saw was actually a vertebral fracture. It was a fracture of I believe a lumbar vertebrae, and they had a bone growth stimulator placed in there to try to get the bone to heal better. So I know my femoral fracture, she did pretty well with hers. The bone growth stimulator did help. And I honestly don't remember with my patient with the back one. All right, so contraindications and precautions to E-stim. We never want to put E-stim on the front of a patient's neck or throat area. So avoid running current through the heart, the carotid, sinuses, arteries, and the pharynx. There's just a lot of really important vessels in through here that carry blood up to the brain, and we don't want to interrupt that at all for anything. Absolute pacemakers. If someone has a pacemaker and that's sending an electric signal to the heart to keep it beating the way that it should, we do not want to interfere with that in any way, shape, or form. Pregnancy, especially over the abdomen, lumbar, or pelvis, again, this is more of the unknown. We don't know exactly what or if this could do anything to the unborn baby, and we don't really want to find out either. So we play it safe, and we typically don't use E-stim with women who are pregnant. Menstruation, the precaution there is potential for increased blood flow. I can honestly say I've never asked, and I've done E-stim, so precaution. We're gonna chalk that one up to precaution. Cancer, infection, those kind of go together. Again, possibility of spreading anywhere. We don't want that to happen. So especially if we get like muscle pumping and increasing blood flow. So we want to avoid those if at all possible. If your patient has exposed metal, we don't want to run E-stim around that. So if they have like an external fixator or metal coming out of their skin somewhere, we don't want to run E-stim near that. If they have implanted metal, a total joint replacement, pins or screws or any other type of hardware, that's fine. You can E-stim over that. We're not going to cause any issues with that. If they have severe obesity, again, as I mentioned earlier, adipose is not going to conduct electricity super well. So we're, again, just worried that we're actually going to get to our target tissue. And epilepsy is typically a contraindication as well. If someone has uncontrolled seizures, we don't want to do anything that might potentially evoke a seizure. So we typically don't do E-stim with them either. So again, your book always kind of finishes up with controversies in treatment. There's plenty of evidence out there supporting the use of E-stim, especially for pain control, muscle reeducation, motor level edema control. Again, we still need a little bit more research when it comes to wound healing, although it does look pretty good, fracture healing, and changes in the tissue pH. All right, we are going to practice all this stuff in lab. I'm also going to give you guys a chart in lab. I'm going to put it up on the board to help you sort of break down the treatment areas and what types of stim to choose and proper setups. So again, we'll cover some more of this stuff in lab, and please let me know if you have any questions. Thanks.